My task today is to talk about prevention of osteoporosis. You know, the old saying, prevention is better than cure. But this word prevention has a lot of misunderstanding. I just gave a talk a few days ago. Then this ENT colleague said, how can you talk about prevention? You know, you still get fractures. His idea is that prevention means you completely prevent fractures. But we know that that's not always true. For any sort of treatment or lifestyle measure, it's never 100%. But then still, there is a significant risk reduction, right? And so it's still worth doing. So when you talk about prevention, we're talking about primary prevention. That means even before the patient has the illness. Say if you had a fracture and prevent further fractures, we're not talking about that. That would be considered under treatment. If you have very low BMD, you have osteoporosis, no fracture yet, that's also not prevention, that's treatment. So what I'm talking about really is lifestyle measures, which everybody can do, whether you are a low-risk patient, a medium-risk patient, or a high-risk patient. So in your guidelines, you will see that this kind of approach is more like a population-based approach. Because these measures that I'm going to run through with you this afternoon is for everybody, no matter what your risk is. And this is something that is easy to do and generally effective if the people actually do it, and that's the problem, right? Because a lot of people don't actually do these things. So first of all, let's talk about calcium. Calcium in young people is very important, and this was a study done in the 90s, although not published. It's in a group of 21-year-old girls who are approaching peak bone mass. And you see analysis by quartiles, you find that the BMD goes up as the calcium intake goes up. And this is also the same, there's data like that from Hong Kong as well, and this is for the neck of femur BMD in these girls. You see the correlation between the BMD and the calcium intake. So calcium intake is extremely important, more so in the developing years. So, you know, nowadays teenagers moving away from drinking milk is really not a good idea. But over the years, I think on the whole, the population has improved in terms of calcium intake. Here you see in a study in 2004 that the average daily calcium intake is 627. A similar study in the 1990s, it was only 448. So generally, our population is actually taking more calcium, which is a good thing. And low calcium intake has been shown in many studies to be associated with low bone density and a higher risk of fracture. So calcium intake does have a role to play in terms of osteoporosis fracture prevention. There's also a study in Hong Kong where they supplemented with milk, and that too seems to work because milk, after all, is a source of calcium. Some of these things I'd like you to refer to yourself. In your guidelines, there's a helpful chart of calcium content in various foods, and also a table, table 4, where the calcium and vitamin D daily requirements are there. So I'll leave you to refer to that. And there are also studies to show that calcium with vitamin D supplements will decrease fracture risk, especially in those who are deficient. But if you're already not deficient, you take more calcium and vitamin D, is not really going to help you. So if you're deficient, yes, you should really try to get up to what you need every day. And our recommendations are in table 4. In the famous Women's Health Initiative, there was a trial using calcium and vitamin D, 1,000 milligrams of calcium and 400 IU vitamin D, and that reduced the risk of hip fracture in older women, but not on the hip though, but not in other sites. So there is some evidence here and there that even simple measures like calcium and vitamin D can reduce fracture risk and is good for your bones. But then that brings me to this very, very important slide, which I've made much bigger than my other slides, you see, because this is very important. A common lay misconception that requires correction is that having an adequate daily calcium intake protects against osteoporosis, and it's important to remember that patients with risk factors still require evaluation and require therapy over and above adequate calcium. This is very important because in the early days of our campaigns and all that, there were a lot of vested interests, and people are trying to sell things to say, you take our product and then your bones become miraculously better and then your fracture risk drops. And that would be doing your patients a disfavor if all you give them is calcium and vitamin D if they're at high risk osteoporosis. So do remember that although there is some data that shows that calcium and vitamin D supplements help prevent fractures, they are not everything, particularly in high-risk patients. Okay, this slide just to tell you that vitamin D is something new. It's something old but something new. All of us in school learn about vitamin D. It's good for your bones. But it turns out that vitamin D is found in almost 30 over tissues in your body. And now if you look at the literature, vitamin D has swung to the other end of the spectrum. It's good for everything under the sun. It prevents cancer, it prevents heart attacks, it prevents autoimmune disease. But having said that, today we are focusing on the bones. And this slide is very busy, but highlight a few things to you. First of all, the sun. The sun is the major source of vitamin D. It turns out that in food, the sources aren't that adequate, most of the time. And if you avoid the sun, you will generally have low vitamin D. I see this in my patients with lupus and dermatomyositis. They must avoid the sun. They almost always have low vitamin D, right? So similarly, in our climate, although the sun is always there, it's no use if you don't go into the sun. So if you're elderly, you stay at home. If you're young, you want to preserve a white, smooth skin, you stay at home. So then the vitamin D levels drop. So this is actually more common than we think, and there is evidence for that. Well, how do you define what's low, what's not low? Generally, we take a cutoff of about 20 or 30, depending on what studies you apply. And this 25-hydroxy vitamin D is the best gauge of whether a person is vitamin D deficient or not, generally. Right? And if you take 30 as a cutoff, a study by Lips shows that in various countries around the world, the prevalence of vitamin D inadequacy is quite high, even in places like Middle East, perhaps because of cultural factors. They need to cover up the skin so they don't get vitamin D exposure. And even in Asia, and there have been studies in Malaysia, in Thailand, in Hong Kong, that show similar findings that actually is much more common than we thought. And this is just one of my patients to illustrate the point. I have an elderly patient who had back pain and fractures in the spine, terribly low T-scores, and I gave her Forteo, followed later by a bisphosphonate, and she had the prerequisite she had the gains in BMD, but her vitamin D levels are extremely low, 15, So this is just to show you that even when while she's taking Caltrate and vitamin D supplements, which only have 200 IU, you can still get vitamin D deficiency. That is something to really, really think about in the more elderly patients. And there have been many studies done too on vitamin D and the bones. A meta-analysis of vitamin D, all sorts, native and analogs together, showed that it did not reduce fracture. This is one meta-analysis. The references are in your guidelines. However, there are other studies that show that it does. So vitamin D with calcium in another study marginally reduced hip and non-vertebral fractures, but only in those who live in institutions. So if you're in an institution, clearly the bone health is much poorer. And then another meta-analysis concluded that oral vitamin D, this kind of level, 700 to 800 IU a day, reduce the risk of hip and non-vert fractures, again in the institutionalized. Right? And then further meta-analysis showed that vitamin D analogs have some role to play. So again, like calcium, calcium alone, vitamin D alone, calcium with vitamin D, there's a smattering of data that shows that it is of benefit. But the other interesting thing about vitamin D is not just the bones per se, but its effect on muscle strength. If you have adequate vitamin D, it improves your muscle strength, the balance, and generally your lower limb function. And if that's good, your risk of falling is less. So if you are vitamin D deficient, your risk of falling is higher. And I think Dr. Au will talk about that next, so I won't dwell on that. But again, there are studies showing that vitamin D supplements have an impact on the risk of falling. That means if you give vitamin D, it will reduce the chance of falling, especially in the elderly. And this is important because, as you know, for fractures like the hip, generally if you don't fall, you don't fracture. So risk of falling, prevention of falls is extremely important, and that will be the next talk. But all these studies show that whether it's plain vitamin D, alpha-calcidol, calcitriol, there is some data in terms of reducing falls as well. And so this is the guidelines grade B level 1 recommendation that vitamin D supplementation with calcium should be considered in most individuals, especially in the elderly and those in institutions. Vitamin D analogs should not be used as first line because there are side effects to look out for, particularly hypercalcemia, so it should be treated like a drug. And so this recommendation is grade B level 1 plus. Although not grade A, this is a simple measure which everybody can do. So that's why it's highly recommended. Okay? And so next, exercise. Specific training programs have been shown in clinical trials to be of benefit. And exercise in general will improve the well-being, the muscle strength, and the postural stability. So what type of exercises? Well, weight-bearing, high-impact, resistance training. What are these? Resistance exercises use free weights or weight machines. All this is in the guidelines. I leave to your reading. Weight-bearing exercises such as aerobics, brisk walking, jogging, jumping, something that has an impact on your skeleton. The frequency about 2 to 3 times a week. And this is about the kind of duration that is recommended. And of course, if they've never exercised, then you need to take precautions. You need to make sure that they can commence exercise and need to do it gradually. And so exercise together HRT and calcium has been shown in some studies to be better than if you omit exercise or if you just do exercise alone. And so we have groups like this conducted by Osteoporosis, but also I think by other groups, community centers and all, where people get together to exercise together, and that's really a good thing. Then lastly, cigarette smoking and excessive alcohol. So both cigarette smoking and excessive alcohol should be avoided. Grade C, but again, this is also bad for other parts of your health. So although grade C is highly recommended too for osteoporosis, although the evidence is not that strong. Okay? And so in conclusion, preventing osteoporosis is something that must be done by many parties, not just one. This is an example. In 2002, we partnered Health Promotion Board, which we still do. Southwest CDC, we partner a lot. Osteoporosis Society. All different groups must come together to prevent osteoporosis, and that's very important. And so in this final slide, you see the usual suspects in front. People are very interested in osteoporosis. You see the people behind who are terribly important too. These are our patients. and their caregivers who are very active members of society. They are the people who learn the messages, who know what's going on, and they spread the message for us. But what is missing from the photo is all of you. I wish I can put all of you inside. Because primary care physicians, I feel, are very important in the prevention and treatment of osteoporosis. I view osteoporosis as an illness like hypertension. You don't see everybody with hypertension going to a specialist, right? Majority of hypertension is treated by the general practitioner, and I think that should be the case too in Singapore. So all your faces should appear here, and together we all should have this logo, which is hidden, but it stands for Build Strong Bones for Life. Thank you very much.